Welcome. Thank you for joining the University of Minnesota's webinar series presented by the Consortium on Law and Values, entitled When Law, Ethics, and Medicine Collide. At a time of growing conflict between the demands of patient care, medical ethics, and the law, we are bringing together experts with multiple points of view to discuss these crucially important issues. I'm Susan Wolf, Regents Professor of Law and Medicine and Faculty Chair of the University of Minnesota's Consortium on Law and Values in Health, Environment, and the Life Sciences, the sponsor of this webinar series. Today, we have three top experts from the US and Canada to address a pressing debate, considering medical aid in dying. Debate about medical aid in dying, often called MAID, M-A-I-D, is pervasive now across the US, Canada, and actually much of the world. But even the terminology remains contested. So you hear terms including medical aid in dying, medical assistance in dying, both often called MAID, but you also hear physician-assisted suicide, euthanasia. All of these terms are contested. But controversy over physician administration of life-ending drugs, such as by lethal injection, or provision of medications to patients so that patients can take their own lives, controversy over those practices is really as old as medical ethics. Hippocratic writings committed physicians to give no deadly drug, even if asked, and debate has waxed and waned ever since. In recent years, the issues have taken on new life, especially in the US after the Supreme Court decided Vacco v. Quill and Washington v. Glucksberg, two cases deferring to the laboratory of the states, as the court calls it, on the question of legalizing physician prescription of life-ending medication. And at this point, multiple states, as well as the District of Columbia, have statutes on the books or a court decision that authorizes medical aid in dying for adults who are terminally ill. And many additional states, including ours, Minnesota, are currently debating similar measures. First legalized in 1994 under the Oregon Death with Dignity Act, which went into effect in 1997, the state statutes on the books authorize physicians to prescribe lethal medication that the patient may choose to take. Unlike Canada, in the US, no state statute authorizes physician direct administration of life-ending medication. But evolution of state law continues, and debate certainly continues. Our expert speakers are going to talk about that debate and that evolution. In Canada, the federal authority has authorized both provision of lethal prescription and physician direct administration. And again, we have a very experienced speaker from Canada to talk about developments there, which are extremely interesting and extremely controversial. We want to discuss from our US perspective, is Canada a model or is Canada a cautionary tale? Our panelists are experts on law, ethics, and the clinical realities of medical aid in dying. They bring different perspectives and different disciplines to this important debate. Thad Pope is professor at Mitchell Hamlin School of Law, where he directs the Health Law Institute. Dr. Sonu Gand is professor of medicine at the University of Toronto, where he's chief of psychiatry at Humber River Hospital and co-director of the Adult Psychiatry and Health Systems Division at the University of Toronto. And Dr. Nancy Berlinger is a senior research scholar at the Hastings Center. I'm going to introduce each of them in a little more detail in just a minute. Each of them is going to speak for about 15 minutes. We want to preserve lots of time for your questions and for conversation among our speakers. So after each speaks, we're going to open it for panel discussion and QA. I'm delighted that Professor Francis Shen, co-chair of the consortium and professor of law here at the University of Minnesota, is going to join me at that point in co-moderating the discussion. So let me do just a little bit of housekeeping before I introduce Professor Pope. Please use the QA function in Zoom to ask your questions and fire away. We really want to hear what you have to say and what you're concerned about. That's really the point of today. If you want to tweet or use X, please use the hashtag medical aid in dying, all run together, and look for consortium tweets at UMN Consortium. If you have any technical difficulties during the webinar, we are very eager to help you. All you have to do is email consortm@umn.edu. That's consortm@umn.edu. Our staff is standing by. They're happy to help. And I'd like to thank our tremendous staff and the University Video Services for managing the logistics of this webinar series. I'd also like to thank the University of Minnesota Law School for their invaluable assistance today. This webinar is being recorded. The raw recording is going to be posted on our YouTube channel and website immediately after the event, and a slightly edited version, you know, if there is a glitch or whatever, will be posted several days later. But we absolutely encourage you to share it, use it in teaching, use our video in any way that you see fit. Everybody who's registered for the webinar is going to get a brief evaluation to complete following the event. We read every single one. I read every single one. So please take a few minutes and give us your feedback. And finally, disclosures. Dr. Gann discloses that he was retained by the Attorney General of Canada as an expert in the Truchon and Lamb cases that challenged the nation's MAID law. Our other speakers and moderators have no relevant disclosures. Okay, so let's get going. Let me now introduce Professor Thad Pope. And each of our speakers is so accomplished. This is the short version for each of our speakers, because I don't want to invade too much of their time. Professor Pope is an expert on medical law and clinical ethics. His work focuses on patients' rights and healthcare decision-making, especially at the end of life. A fellow of the Hastings Center and previously both a Fulbright Canada research chair in health law policy and ethics at the University of Ottawa, and a visiting scholar at the Brochet Foundation in Switzerland. He is now a professor at Mitchell Hamlin School of Law in St. Paul, Minnesota. Professor Pope has been a regular consultant to the American Clinicians Academy on Medical Aid in Dying, which is an advisor to end-of-life organizations. He's a frequent witness testifying in legislative hearings on MAID and an expert witness in litigation concerning assisted dying. I'm going to turn it over to Professor Pope.
Thank you. I'm just going to load up my slides here. All right, thanks for having me. Looking forward to this. This year, in 2024, 3.5 million Americans are going to die, 55,000 in Minnesota. Many of them want to control the timing and the manner of their death. Sometimes that's because of physical suffering, like pain or nausea, dyspnea, or paralysis. Or it's because of existential suffering, like psychic pain, loss of control, anxiety, delirium, or hopelessness. These patients want to control the timing and the manner of their death, because in their judgment, the burdens of their life seriously outweigh the benefits, right? They might have lost the ability to enjoy activities that are meaningful to them, or they fear illness-related suffering, or they fear losing control and independence. And today, many dying patients do already control the timing and the manner of their death through at least 5 end-of-life options. They can complete an advance directive, declining life-sustaining therapy. If they're already on life-sustaining treatment, they can have that withdrawn. They can have high doses of opioids, even if that hastens their death. They can have palliative sedation to unconsciousness, and they can voluntarily stop eating and drinking, or VSED. Patients already use all 5 of these end-of-life options in Minnesota every single day. So what we're going to talk about is a 6th option, medical aid in dying, or MAID. So here's the roadmap in 4 parts. First, what is MAID? Where is it authorized? How is it working? And what's new? What's coming up next? So what is MAID? It is an end-of-life option that's available to a small number of patients. First, it's only available to adults, people 18 years and older, and only adults with decisional capacity. Sometimes we say they're competent or they're mentally capable, but what we mean is that the patient understands the nature and the consequences of this choice. Nobody can request MAID for somebody else, right? Can't be a guardian, can't be a healthcare agent, can't be a surrogate. The patient themselves has to make this decision. And third, they have to be an adult. They have to have decision-making capacity. They also need to be terminally ill, right? Which means they're in the final stage of an incurable and irreversible physical medical condition that will probably cause their death in the next 6 months. So they're at the very end of their illness trajectory. So to recap, this is for adults who are competent and terminally ill. So if you are eligible, what is it? What is the nature of the healthcare service here? Well, you can ask and receive a prescription drug that you then might self-administer to hasten your death. Almost always, that drug is a compounded medication, DDMAPH. It's digoxin, diazepam, morphine, amitriptyline, and phenobarbital. This will put you to sleep in about 3 to 8 minutes, a deep sleep, and cause your death within 45 minutes. There are 3 ways to take the medication. Most people mix the powdered medications with 2 ounces of apple juice and drink it. But you can also press a plunger on a feeding tube or press a plunger on a rectal tube. It's only those 3 routes. That's it. Right? There's no intravenous or IV administration. And also, other people can help you prepare the medication. So for example, take the powders and mix them with the 2 ounces of apple juice. But nobody else can help administer them, in other words, making the drugs go into your body. Right? The patient alone has to take that final overt act. Right? And that's important because otherwise we'd be talking about euthanasia, which, while it's available in Canada, is not anywhere in the United States. So nobody can administer the drugs to the patient. The patient has to do it herself. Okay, so now we know what MAID is. Where is it authorized? It's authorized in these 11 jurisdictions, the red ones. And it started, as Dr. Wolf said, in 1994 in Oregon. And because of Oregon's solid patient safety track record, that Oregon model was then followed by other states. First by Washington in 2008, in Montana in 2009, in Vermont in 2013, in California in 2015, in Colorado in 2016, in Washington, D.C. in 2017, in Hawaii in 2018, and then both New Jersey and Maine in 2019, and then finally New Mexico in 2021. So as of today, MAID is authorized in 11 US jurisdictions. And 75 million Americans live in those states. Now, of course, MAID is not static. it's changing. So this year, just in the first 5 months of 2024, we saw 50 bills in at least 20 different states. Perhaps most notably, bills in New Hampshire and Delaware have passed at least one chamber of their state legislatures. And here in Minnesota, as Dr. Wolf mentioned, we have an active bill, HF 1930, which has passed 4 House committees, although is stalled in the Senate. The session ends in less than 3 weeks on May 20th, so it's a little bit of a race if that's going to pass this year. So what's been the experience in the states that have MAID, right? If you add up the years that MAID has been available in each of the 11 jurisdictions where it's available, you get 104 years of combined experience, right? And almost all those states produce an annual report summarizing the experience with MAID. So now we have like 100 Department of Health reports, right? That's a lot of data, right? What does it show us? What does that data show us? Well, it shows that US clinicians have written 15,000 MAID prescriptions, and about 10,000 of those have been ingested by the patients, right? Who are the patients getting these prescriptions? Well, we know that you need to have a terminal illness. Most of the time, 76% of the time, that's cancer. 14% of the time, it's a neurodegenerative disease like ALS, and 10% of the time, it's a cardiovascular disease. Other demographics, 95% of these patients are insured. 72% have completed at least some college, relatively well educated. 95% are white, and there's about a 50-50 male-female split. In terms of age, as you would expect, most MAID patients are older. 76% are over age 65. 16% are between 55 and 64, and only 8% are under age 54. And then finally, 90% of MAID patients are on hospice. And that figure is particularly important because at least a third of the patients who get MAID prescriptions don't take them, don't ingest them. And if you look at this graphically, this green line is Oregon data. Those are the prescriptions written, and the lower purple line are the prescriptions taken or ingested. And that's because people get MAID just in case their suffering becomes intolerable. And because of good hospice and palliative care support, often it doesn't become intolerable. So they have the MAID just in case for comfort and for peace of mind. Maybe in the same way that we have insurance, right? We hope we don't need to make a claim, but we have insurance just in case. So what else does the data show us? It shows that there's a solid patient safety track record, right? There are numerous safeguards built into all these laws. Some people say guardrails. The patient has to make multiple requests for MAID and have multiple screenings by a prescribing physician and by a consulting physician, and sometimes also by a mental health physician, to make sure that in fact the patient is terminally ill, that they have decision-making capacity, that they've carefully considered all of their alternatives. This is just one flow chart illustrating the steps that the patient must navigate in order to become eligible for MAID. To make sure that this choice that they're making is voluntary, informed, and enduring. There's no evidence of abuse. In 100 years of combined experience in 11 states, no patient got MAID who didn't want it. No clinician had to participate who didn't want to, and no entity had to participate that didn't want to, right? This is completely voluntary and optional. It's opt-in only. So let me just end with talking about some innovation, what's coming up, what's happening now, what's new and different. So as I said, MAID is available in these 11 states. And for a long time, each state followed the Oregon model very, very closely. So all the laws were nearly identical. Why not, right? The Oregon model was safe and effective. It was proven. Why not follow it? Well, there was an increasing focus on access, the question of access, which is, can patients actually get it? Right? So for a long time, the debate was very binary, which is it legal or is it not legal? But today, the focus is more on what are the exact terms and conditions under which MAID is available. And so let me just tell you 4 things that are really changing across the country. The first is who can prescribe. In 8 states, it's only physicians, an MD or DO. But in 4 states, it's also an APRN or a PA. Another variation is who can do the mental health assessment. In 6 states, it's only a psychologist or psychiatrist. But in 5 states, we allow other types of licensees to do that mental health assessment. Another variation, how long is the waiting period? So in 5 states, the patient has to make 2 oral requests for MAID separated by at least 15 days. And that's the traditional Oregon model. Right? This used to be required in all states. But the evidence shows that that constitutes an undue burden. Many patients can't wait that long. They're going to die or lose decision-making capacity before the 15 days. So, right, 6 states shortened that waiting period or allow a waiver or exemption if the physician certifies the patient can't wait that long. And then the final variation is the residency requirement. Originally, every state said you need to be a resident of this state to get MAID in this state, right? So for example, California permits MAID only for California patients. But that residency requirement is being removed. It was removed in Oregon, it was removed in Vermont, and there is federal litigation challenging it in New Jersey because New Jersey is discriminating between residents and non-residents, and the lawsuit challenges that violates the privileges and immunities clause in the US Constitution. So those are just 4 variations on MAID laws. This year, if you look at all the 50 bills from 2024, those variations are continuing in all the new bills. And there are more variations to talk about. Let me just tell you 2 things that are coming up next. One is California. This is a bill, SB 1196, and it's a pretty big deal. And here's why. The stuff we just talked about which types of clinicians can participate in MAID, how long is the waiting period, is there a residency requirement? You might call that MAID 2.0, right? Sort of the new changes in the last few years. This California bill might properly be described as MAID 3.0, right? Because it proposes to eliminate the traditional 6-month prognosis, the terminal illness requirement. And it proposes to allow not just ingestion of the drugs, but IV administration of the drugs. Nobody's done that before. One last thing, in West Virginia, the state legislature passed a resolution to criminalize MAID in the state constitution. MAID is already illegal in West Virginia. This would just embody it in the Constitution if that gets ratified by the voters in November. So a lot of variations. So in conclusion, Minnesota patients already control the timing and the manner of their deaths every day, and MAID is just one more option. Thank you.
Thank you, Professor Pope. We're getting great questions in the QA, and I want to make sure you know that you can also use that thumbs up icon to endorse a question and make it rise higher up on the list so we see that there are multiple people who'd like to see that answered. So please go at it. We want to see more and which of these questions a number of you would like to see addressed. Our next speaker is Professor Sanu Gand. Dr. Gand is a professor in the Tamurti Faculty of Medicine at the University of Toronto and Chief of Psychiatry at Humber River Hospital. He works as a psycho-oncology consultant. He is co-director of the Adult Psychiatry and Health Systems Division. He's past president of the Canadian Psychiatric Association and the Ontario Psychiatric Association, and he is president-elect of the Canadian Association of Social Psychiatry. Dr. Gand has been actively involved in health policy development and advocacy and has been recognized with numerous regional, provincial, national, and international awards for his teaching, advocacy, and impact. Dr. Gand.
Thank you, Professor Wolf. And just as I am getting my screen share going, I will just point out that some of the information in terms of my affiliations is different now. Those were some past ones, but I'll show that on my screen as we are starting. So you'll see that the hospital is a different hospital, and other kind of affiliations I'll mention in the next slide. But I want to first start by expressing appreciation, both for this invitation, but also for you covering this very challenging topic. You'll see the picture I paint is quite different from what you've heard about what MAID has become in Canada in less than 8 years since we introduced it in 2016. And the title of my talk is Nothing Nowhere All at Once, Canada's Growing Courtship with Assisted Death. This slide has my disclosures, and these are different kinds of disclosures. It's not so much financial, but we are talking about policy. So I think people's experiences come into play. They do inform my views, but I'm not speaking on behalf of any group I work with. What I will point out is that I have clinical experience in psycho-oncology, working with people who are in the process of living and dying with cancer. And I also am not a conscientious objector. I actually chaired my former hospital's MAID team that was at Humber River, but I do have concerns about the expansions that are happening. So I will quickly go through what has happened in the past 8 years and then spend a bit more time on some recent expansions we've had. So our MAID laws came into play in 2016 following a Supreme Court ruling in which there were two plaintiffs, Carter and Taylor. One had spinal stenosis, the other had ALS. And as a result of that Supreme Court ruling, the court ruled that the up until then blanket prohibition against assisted dying breached our Charter of Rights and Freedoms. They did not say that everyone needed to be able to access assisted dying, but they said in some circumstances there needs to be a path for evaluation. That led to our Bill C-14 in 2016. And what that did is actually introduce the term MAID. Prior to that, most places were calling it physician-assisted suicide, physician-assisted death. So Canada actually coined the term MAID, medical assistance in dying. And you'll see that what has actually happened with that is very different from what some people believe MAID is about. And what it allowed for is that if you were an adult who had a grievous and irremediable medical condition, as defined by something that's incurable, you're in an advanced state of irreversible decline, and you have suffering that can't be relieved by means you find acceptable, and your death was reasonably foreseeable, you would be able to apply for consideration for MAID. In 2019, that last safeguard, the reasonably foreseeable natural death safeguard, was challenged in a provincial court, and a Quebec judge ruled that that was overly restrictive. And as a result, we are now operating under what came out in 2021, which was Bill C-7, that dropped the reasonably foreseeable natural death safeguard and introduced a new track 2 for people who were adults with any disability, regardless of length of life that they may have. Well, and there was also a last-minute sunset clause introduced, which said that MAID for sole mental illness conditions would also come into play by 2023. Now, with that background, this is what our numbers have been. These are not cumulative numbers. These are year-on-year numbers. So the last year we have finalized data for is 2022. And by that year, over 4% of all Canadian deaths were by MAID. It was 13,241, as you see here. We're expecting 2023 to keep on track with this growth and be about 16,000, which will represent about 5% of Canadian deaths. At this point, we can safely say that more people have had MAID provision and died from that than have died from COVID in Canada. And in terms of the percentages, you see that there is variation between the different provinces, and Quebec and BC have always been the highest and remain the highest. So Quebec is over 6.5% from 2022. Now, how did we get here? You know, I think many of us, myself included, hope that we get here through robust policy deliberations, but this has not been your usual yellow brick road in Canada. I actually term it more of a broken yellow road. And the troubled waters begin when we try to understand what has led to these expansions. The issue I'm going to focus on for the next about 7 minutes is mental illness, because many of the issues related to the mental illness expansion also are issues for the broader expansions we've had to disabilities in Canada as well. But in terms of the evidence, let's see what the evidence shows. You know, people have said it would be discrimination not to provide MAID for sole mental illness if it's provided for other conditions. But again, equity doesn't mean everything is treated the same. It means it's treated for what it is. And in fact, if things are different and warrant different treatment, they need to be treated differently. So let's look at mental illness. There are many things that change how we think while we remain competent with mental illness. The known cognitive triad of I am bad, the world is bad, and the future will be bad is only the start. We also lose cognitive flexibility. Stresses that we normally bend to, we break to. And we focus on the negative, lose the ability to actually see the positive. And even physically, we see there are functional changes in the brain that correlate with the loss of ability to see a future. In other words, hope. And that's before we even get to these other two issues of can we predict who will not get better, irremediability, and can we separate suicidality? The short answer for both of those two fundamental questions is actually no. You know, apart from the issue of whether we're talking about whether mental illness symptoms get better or the social suffering attached gets better, we know that we are less accurate at predicting whether somebody's mental illness will get better or not than flipping a coin. Less than 50% accuracy is what the evidence shows. And in terms of suicidality, we've had senior policymakers and many people advocating for expansion of MAID, saying that we can separate requests for psychiatric MAID from traditional suicidality that benefits from suicide prevention. The reality is the evidence shows us that's not true. When you actually look at how we're supposed to be able to separate that, you see that virtually every single thing that applies for traditional suicidality also applies for MAID, other than impulsivity and other than whether the person is doing it themselves or not. And in North America, most suicides are not impulsive suicides. So this idea that MAID is somehow different if we're seeking it for psychiatric reasons than suicide is a fallacy. And it's a bit of a mind trick, actually. These are not the suicides you're looking for. Now, when we actually look at this, we have heard in Canada some proponents saying that that's okay, that this is actually from the federal panel that reported on this. They're saying that society's made an ethical choice, even if MAID and chronic suicidality are the same, to provide it. I don't think our society has, but some people in it may have. And when you combine all of that, impact on decision-making, lack of ability to predict force, lack of ability to separate suicidality from psychiatric euthanasia, you find that there are serious differences between MAID for mental illness and other MAID for other medical conditions. I call it Pinocchio syndrome. You know, mental illnesses are legitimate illnesses, but they're not the same on all these issues when people are seeking death. And in fact, rather than evidence, we've often had evidence ignored and kind of straw person arguments forwarded. So the evidence argument fails. In fact, I believe it's discrimination if we ignore the evidence, as has been done with our MAID expansion. What about this? What about the robust process? And this one I have some difficulty talking about because of some of the input from my own profession. But I'll skip the parliamentary process other than to point out that we had 3 hours of debate about whether MAID should be expanded for mental illness after a last-minute addition of the sunset clause. And that passed largely along partisan lines. But in terms of the consultations medically that's informed this, what we find is that the main group, Canadian Psychiatric Association, they said that they haven't taken a position. And I'm a former past president of this association. They said they haven't taken a position, and they said MAID should be available to all patients, however, the second one, if you have mental illness. And when they were asked about, well, what about predicting irremediability, et cetera, they said that, well, we actually didn't consider that in taking this position. Many of us felt that that's really putting the cart before the horse. We also then had contributions to the debate describing from the CPA the exclusion of MAID for sole mental illness as inaccurate, stigmatizing, discriminatory, unconstitutional, yet claiming that they haven't taken a position. Naturally, policymakers felt they have taken a position. But to me, the most startling thing is this, that on these public consultations on death and mental illness, the number of times any evidence related to suicide risk and mental illness, or even the importance of suicide prevention, or even the word suicide was mentioned, was zero by our National Psychiatric Association. That's highly concerning, and many others have raised these concerns as well. So Canadian Association for Suicide Prevention felt that CPA is still taking a position despite stating otherwise. Indigenous leaders across our country felt that they're perpetuating policies of privilege and ignoring suicide contagion. And some of our leaders have felt that this actually was suicide facilitation. The reason it's important is that this is what has informed our policies. Now, the last piece here is there a consensus in the public, or is there a legal requirement? Short answer is no, there is not. There's not been any case, the Quebec case did not look at mental illness, the Supreme Court did not look at mental illness. And while most psychiatrists support MAID in general, as do I, I'm not a conscientious objector, most do not support the expansions of MAID for sole mental illness. So how has all of this happened? You know, if you peel away all of those other issues, then what you're left with is ideology. And I do believe that that's what has fueled our expansions. And that's what I'll spend the rest of my few minutes talking about. Because one of the most common themes has been, well, this is all about autonomy, about right to die. When you look at MAID, when end of death is foreseeable and close, then you do find that people seek it to preserve dignity. And they often have had more privileged backgrounds. So I term it privileged autonomy. When you expand it beyond end-of-life conditions, you actually find other social suffering comes into play. And that's not true autonomy to seek death for that. Most of those people would prefer to live better rather than have death as their only option to escape suffering. I'll skip this slide, but I'll say that the nature of suffering that leads to people's request for death changes as we expand these laws. And what we see from Europe, from the few places that allow psychiatric MAID, it actually is not a gender balance. There's a disproportionate gender gap, twice as many women as men getting it, and people getting it in states of social suffering. You know, when some of the people forming our policies were asked about that, this to me is a striking quote. The chair of our federal panel was specifically asked about the gender gap and said, it doesn't concern me in the sense that I don't think anyone knows what it means. Many of us in the mental health field fear we do know what it means. Marginalized populations have higher rates of completed suicide. Any First Nations population in any country has that, LGBTQ2 spirited, etc. So we think that it does reflect gender-based marginalization. And there are many reasons that people may choose death. It's not just to avoid the suffering from a medical condition. And as we broaden our laws, that's what we're seeing. It does concern me that there are groups that deny this. So Dying with Dignity, literally up until this day, says that it's a myth that vulnerable people can be eligible for MAID if they're suffering from inadequate supports. Well, you know, Canadians have not gotten that memo. Because when you look at what some Canadians are actually getting MAID for in their own words, die when I run out of money, woman with multiple chemical sensitivities who felt that government sees me as expendable trash and died after an effort to get safe housing, woman who chose MAID after not being able to get home care, or a woman who said it's exclusively a financial consideration. These are all well-documented and reported reasons that people are now getting MAID in Canada. This one I would actually encourage you to have a look at. It's very disturbing, but it's about a man who chose MAID after not being able to get adequate care for over 90 hours in our emergency room. And we're seeing headlines like this: UN experts alarmed by trend towards MAID for non-terminal conditions, why is Canada euthanizing the poor, and no other options, referring to people seeking MAID when they have other unmet needs, either lack of access to care or social suffering. So in my opinion, we have gone in a short time from compassionately relieving end-of-life suffering as the intent to now also facilitating and perhaps even enticing death for some for life suffering. And that leads me to the last about a minute and a half of my talk on the path forward. You know, where are we at in Canada? This is remarkable. Twice we've been on the brink of introducing MAID for sole mental illness, and twice the government has stepped back. I know of no other major policy where something like that has happened. To me, that reflects that we haven't followed proper processes to shape these policies. There's a link here. You can see some of the testimony that's informed these discussions. But in the end of the day, just a few months ago, the government said they will delay the mental illness implementation for another 3 years until 2027. I had written on this a fair bit. In this piece, I'm pointing out, along with other colleagues, that we don't even have a national suicide prevention framework. And we're talking about introducing MAID for sole mental illness. And my view is we need to start thinking about how we help people live with dignity before we think that the only reason people might choose MAID is to die with dignity. And, getting back to Professor Wolf's comments right at the beginning, I see Canada as a bit of a canary in the coal mine. I do see us definitely as a cautionary tale. And what I would suggest is that we think about who we want to be as a nation in Canada and elsewhere. Some bioethicists here have said that even if people are getting it for social suffering, that's okay, because that's harm reduction. I don't share that view. And I have 2 more slides after this briefly, but my view is that MAID expansion may be safe for the privileged who have more autonomy to die better, including me. But for others, the non-dying disabled and marginalized who will choose it to avoid life suffering, it'll eventually be called something else. And I think that what we really need to do is ask ourselves the right question. And I don't think the right question is, what is the perfect balance we will find? Because I don't think there's a perfect balance. I think the real question is, which mistakes do we want or are willing to make? And if we are willing to expand autonomy of the privileged while ignoring how that impacts the more marginalized, the next question is, which side of history do we want our policies to be remembered on? And so I look forward to the discussion, and thank you very much for this opportunity to connect.
Thank you, Dr. Gann. Our final panelist is Dr. Nancy Berlinger, who is a senior research scholar at the Hastings Center, an independent bioethics research institute based in Garrison, New York. Her current research focuses on ethical and societal challenges arising from population aging, with special attention to dementia. I see a number of questions already in the QA about dementia, and to housing equity. She has led expert teams to produce ethical guidance for healthcare practitioners on end-of-life and pandemic conditions, including work on MAID and related issues such as voluntary stopping of eating and drinking, VSED. She has served as an expert consultant to public deliberation concerning MAID in the UK, and on the planning committee for the National Academy's 2018 workshop on MAID in the US. She serves on the bioethics committee at Montefiore Medical Center in the Bronx. I might mention that Dr. Berlinger, Bruce Jennings, and I are also co-authors of the Hastings Center Guidelines for Decisions on Life-Sustaining Treatment and Care Near the End of Life. Dr. Berlinger.
Thank you so much, Professor Wolf. It's a pleasure to be here with my co-author, Professor Susan Wolf, and also my colleague, Professor Pope, who I've edited for many years. So thank you for the team for advancing my slides. We can just go past the title slide. Okay, so most people in aging societies, such as the 2 we've especially been talking about today, the US and Canada, will die of age-associated health conditions that they may live with for months or years before death. And the ethical and legal landscape of later life includes more than medical decision-making about these conditions, and it includes more than decisions to control when one's own death occurs. So if this thought hasn't already occurred to you, I encourage you to set aside the idea that ethical questions about MAID can be settled by whether one personally is for or against them. So let's consider where these provisions sit in later life, in our aging societies, and with respect to one strongly age-associated condition. Next slide, please. So here, if you ask probably any older person, what are the things they're thinking about? This is probably the list that you would eventually get. And there's copious research on this in social gerontology and other fields. People are concerned about what a good life is in late life and how deteriorating health may impact their well-being. They want to know if services and supports that they need associated with age-associated conditions are actually available where they live. Housing is important there because housing access, affordability, and ability to remain part of your community is, in a way, a service and a form of care. Financial costs loom very large, especially in the United States. The cost of age-associated services and supports not covered by health insurers is a major burden to individuals and to families. Most adults in the United States are moderate income, nor wealthy nor eligible for subsidies, and may struggle to cover their unreimbursed care costs. The availability of limits and needs of unpaid caregivers is another factor that separates someone's experience of aging. Unpaid caregivers are almost always female relatives, a spouse, a daughter-in-law, who may manage, provide, and or finance care. Paid care workers are also part of this picture, and often, almost always women, often immigrant women, but the typical person who you picture as a caregiver is a family member. And also community commitment to avoiding not only ageism and ableism, the idea of sort of suggesting that older people are different from the rest of us, our seniors or something like that, but how willing are we to keep people in later life as members of the community? This isn't limited to respecting their decision-making capacity, whether or not they have it, or how healthy and active they are. Next slide. So this, I'm going to be borrowing from a report that we've just released from the Hastings Center. Professor Pope was one of our co-authors. The entire text is available open access. Next slide. So the condition that I hinted at that I would be talking about is dementia. That it gives us an interesting way to crack open some of these ethical questions. We have been using this particular slide for years because it helps to show that the long trajectory of dementia, which on average is about 6 to 8 years from the first appearance of symptoms to death, breaks into 3 different phases. There's different ways of describing these more technically, but most members of the public are familiar with talking about early dementia or moderate dementia or advanced dementia. It's a common mistake to imagine that everyone with dementia lives in a nursing home or has advanced dementia. 70% of Americans with dementia live in the community, either their own home or someone else's home. So the decisions that a person with early stage dementia faces is, should I do advanced care planning while I still have decision-making capacity? Because decisional capacity is lost relatively early in this condition. Should I try some of the very, very new drugs with potential to slow progression? We don't really know whether the slowing of progression that you can see on a scan is actually perceived or experienced as a benefit by an individual or by a caregiver, but this is a very new part of the picture that we need to keep our eye on. But it would be a mistake to imagine that there is an imminent purple pill solution to dementia for our aging societies. When a person has moderate dementia, often on the other side of loss of capacity, the questions that loom are how to live, what is well-being, what does my life mean, what gives me purpose and pleasure and joy, where should I live, who provides my care, and how to pay for my care. And when a person has advanced dementia, they typically need 24/7 care. This would be the situation where a person would often be in a nursing home or in a memory care assisted living. And maybe if they're quite wealthy, they might stay at home, but that would be a very expensive proposition in the United States. Throughout this trajectory, you see unreimbursed care costs that go higher and higher and higher, and more and more and more need for care, especially for caregivers, family caregivers, I should say. Next slide, please. So the takeaways of this report is that ethical and legal aspects of decision-making about the end of life, including the unsettled questions about professional involvement in a terminally ill person's decision about when their own death occurs, the idea that Dr. Gand alluded to about being a conscientious objector or not, should be connected to broader social efforts to improve the experience of living with dementia and to reduce hardship for caregivers, because this is well documented. And this report has many, many recommendations for policymakers, research funders, practitioners, grounded in ethical principles of inclusion, equity, and caregiver support. You notice it's not a hard focus on autonomy or self-determination because of the fact that we are talking about a population where people typically lose their capacity to make many decisions. Next slide. So very quickly, I'm just going to walk through the sections of the report. There's a landscape review, an expert review of the status of these different provisions. Professor Pope was one of the authors of the landscape review. It was led by dementia policy expert Emily Largent. And among the provisions that are considered in the context of a person who has a primary diagnosis of dementia, it's not cancer with some dementia in the picture or heart disease with some dementia, it's only dementia. So we set ourselves a hard problem, would be that this person can refuse potentially life-sustaining interventions while they have capacity or via a surrogate or via advanced directives. The status of voluntary stopping and eating and drinking, while as Professor Pope has mentioned, it certainly goes on. It can be very institution by institution. How will this person actually make a decision? How will they have their palliative care needs met? Can be very much a hospice level policy. And that's a very evolving area. And Professor Pope knows a huge amount of that. Very unclear is whether or not a person could decide in advance that when their dementia progresses to a certain stage, typically advanced dementia when they're in a nursing home, that they could then request that other people limit or even stop their feeding. This is very, very unclear in the United States. It isn't just a legal matter, it's also a practice matter in terms of how do bedside caregivers feel about, how would they feel about implementing a directive like that. Medical aid in dying in US jurisdictions were legalized. People with dementia are basically excluded because of the loss of capacity plus the 6-month prognosis don't line up for dementia. Although, as Professor Pope mentioned, this new California provision could change that quite a bit. And then, of course, euthanasia is illegal in the United States. Next slide, please. So in the landscape review, the authors conclude that while hastening death is a topic on which reasonable people disagree, we can't avoid it in discussions of professional ethics concerning the care of people facing terminal illness, because patients do have the right to make decisions that might cause their death to occur sooner rather than later. They might make a decision that would be an attempt to die before a certain development in their illness trajectory. And professionals are involved in these decisions. So the goal of the landscape review is not to make these hard recommendations, but rather to support discussion, debate, and deliberation in areas of practice like hospice and primary care. The typical medical provider for a person with dementia is a primary care provider, recognizing that this is a community-based population. So it's meant to be very, very practical. And indeed, when we announced this, this project, before the pandemic, I heard from 2 primary care doctors in totally different parts of the states who said, I hope there's something in this report for practitioners like me. Even before we know how to talk with our patients, we need to know how to talk with each other. So I hope we've delivered on that. Next slide. So 3 of these essays provide additional guidance by rethinking some very familiar concepts in professional ethics, in bioethics, that were never designed really with dementia in mind. One of them is the idea that conversations about end-of-life issues are difficult, which could make it very hard for a person who is facing the early loss of decision-making capacity to bring something up. We've learned from medical anthropology research in the state of Vermont that one of the social consequences of MAID legalization is that doctors report that it's easier for patients to bring up these issues. Whether or not they ever request a MAID prescription, they can allude to the provision, and the doctor usually says, oh, tell me why you're bringing this up today. The co-author of this essay is the person who conducted that research, Professor Mara Bookbinder. And she says perhaps a better metaphor would be opening the door, letting the patient direct where the conversation is going, rather than saying, this is going to be very difficult, or you're not ready, or you're not eligible, kind of creating barriers. And there's two other essays, one about the significance of 6 months, which is a problem-solving tool that doesn't solve problems for people with dementia. It's not remotely related to the dementia trajectory, and advanced directives and how to make them work better for people facing dementia. Next slide, please. So finally, the last essay in this collection is a really bold take, reflecting that community-based context, reflecting dementia expertise, and really interesting work that's going on in different parts of the United States. Professor of Medicine Barak Gaster, who's at the University of Washington, Seattle, who's a primary care physician, and Emily Largent, who also led the landscape review, offer an argument for why we should align primary care for people facing dementia with broader social efforts toward greater support for the experiences of living with dementia and dementia caregiving. They draw on the vocabulary of the dementia-friendly movement, which I should add in the United States really was pioneered in the state of Minnesota, and their clinical and research expertise in dementia. They map all of the areas of needed work to improve medical care, community support, and social policy. This would bring together work that tends to be done in clinical settings and in medical schools with work that's being done in nursing, in social work, and really ground-up community-based efforts. I should also mention, given that we're virtually in Minnesota today, that University of Minnesota Duluth School of Medicine is home to highly innovative work on understanding dementia in Native American and Native Alaskan communities. And this is led by my colleague, Professor Jordan Lewis. Next slide, please. So I'm going to wrap with the good you can do. Whoever you are, wherever you are tuning in from, whatever country you're in, whatever your personal or professional views on decisions to control when a person's death occurs, you can create or join local efforts that are leaning toward making communities more dementia friendly. You can advocate for better policies concerning health coverage, care worker protections, home care affordability, and housing. To lessen the financial hardship of a dementia diagnosis. You can advocate for better residential care, increase diversity and representation in dementia research, which people who are Black or Hispanic have a much higher risk of developing dementia. We need to understand why. And we can reframe dementia from an individual or family's bad luck to a foreseeable consequence of human longevity. We all have a stake in that. Next slide. So here are some normative questions to set us up for the discussion. I see there's so many questions as well. We recognize that terminally ill people have the right to say enough to unwanted medical interventions, even when foregoing these interventions may make death occur sooner. So how should ethics, law, and practice offer equivalent choices to terminally ill people who are not facing a decision like this? This is sort of the dementia dilemma. Would a shift in focus from interventions to illness trajectories better reflect and respond to the needs and concerns of people facing different trajectories? So we don't keep working with a cancer paradigm in mind or a heart disease paradigm, so that we're not excluding millions and millions of people with conditions like dementia. And also, why should an individual level option such as MAID never be framed, offered, or expanded as a solution for problems resulting from societal failures to invest in housing, healthcare, or social services? Dr. Gand talked about some of these possibilities as well. And with that, I am done. Over to Professor Wolf.
Thank you so much, Dr. Berlinger. Okay, now we're going to go into gallery view with all three of our panelists, and I'm going to welcome my colleague, Professor Francis Shen. We have a tremendous lineup of questions from you. Keep them coming. Keep those thumbs up, endorsements of the ones you most want to see answered coming. But I'm going to ask Professor Shen to kick off the questions.
Well, thanks, Professor Wolf. Thanks to everyone for a wonderful panel. We have, as Professor Wolf said, over 50 questions already. And what I'd like to do is pick the most upvoted one, but also a question that sort of, I think, encapsulates some of the core dilemmas here. The question comes from Hannah Oleason, and the question goes like this. Can you, I think each of you have perspective on this, can you help us understand the ethical difference between, on one hand, a decision to withdraw life support versus two, a decision to administer life-ending medication? You know, from some religious and cultural perspectives, there's a big difference. In the law, there's a big difference, but MAID laws, these new laws, seem to imply that for an individual, both options might be ethically acceptable. And so if that's true, Hannah follows up with this question. If a parent or guardian can decide to withdraw life support, and if there's some sort of ethical equivalence between withdrawing life support and supplying medical assistance for dying, why wouldn't we have that same rule for MAID? That is, when we get to MAID 4.0, could we have expansion to allow guardians to make this MAID decision for the loved one that's in their care? That's several questions roped in one, but with so many, I thought it was fair to do. Maybe we could just go in the order that we had the presentations. If Dr. Pope and then Dr. Gain and Dr. Berlinger, you all want to weigh in.
I think it's worth reminding people, right, that this was the argument presented to the U.S. Supreme Court in 1997, right? So my frequent co-author, Tim Quill, basically made an equal protection argument to say you have two similarly situated sets of patients. They're both dying. These patients happen to be dependent upon a ventilator, and they have the right to turn that ventilator off. These dying patients over here don't happen to be dependent upon any technology that they can turn off. So they don't have that choice, but they should also be allowed to hasten their death if that's what they want. The U.S. Supreme Court rejected those arguments, so there is no constitutional problem with treating those two classes of patients differently, right? And there's no likelihood that the current Supreme Court would reverse Quill versus Vacco anytime soon, right? So, but to your question, Dr. Shen, that doesn't mean that the states can't just legislate it as a matter of state statute. I think it's likely that they will, because I think it's becoming increasingly obvious, right, that there is this unfairness to treat the two classes differently, and we are moving more and more, right? So we first enact MAID with the first ballot initiative in 1994, but as I tried to illustrate a little bit, the bills are becoming more and more accessible, right? Broader and broader eligibility conditions. Now, nowhere near what Canada is doing, but there's a definite trajectory, right? If we did it on a chart with an XY axis, access is expanding over time, and there's every reason to believe that that's going to continue. And I think that, at least from a patient rights perspective and an individual liberty perspective, it should continue, but bearing in mind Dr. Gann's concerns about patient safety. So it needs to be evidence-based.
Dr. Gann?
Thank you. And it's a very sophisticated question. I think it covers a lot of different areas. And I will say, I actually believe there's a world of difference. There's a world of difference between saying, oh, we will stop life support care and allow someone to die versus we will do an act and end someone's life. It's the difference between omission and commission. And on multiple levels, we see it playing out. First, on practical levels, we know that when we do things for people or make things easier for people, more people do them. That ranges all the way from missed appointments and people following up with those. If you phone somebody after they've missed an appointment, their follow-up is less likely than if you expect them to phone, for example. And that plays out also to suicide. This is one of the reasons we have laws on suicide contagion effects related to media reporting, about how you responsibly report suicide in the media because it leads to contagion. The point is that as something gets done by others, more people do it, the numbers do change. And I will also say that there is a bit of a hubris in saying that, well, we know we're providing death for this reason, when in many cases, that's not the reason we're providing death for. That when we say we can make predictions, we can't, or they won't get better and we don't know that, and we say that's why we're providing it. and they also have social suffering, suffering is cumulative. So the idea that we're ending the life of a non-dying person, somehow that's potentially the same as allowing a dying person to die, to me is a fallacy. And I actually think that it is a dangerous one, because the only commonality there is the common endpoint of death. And there are many different reasons that lead to death, and there are many different reasons people want to die in different circumstances.
Thank you. Dr. Berlinger, do you want to comment?
Sure. I heard in the question that there was the particularly about surrogate decision making. Why would someone be able to make a certain kind of decision but not a MAID decision, especially if the decision to say withdraw a ventilator would be very likely to lead to the person's death. And when we were working on the landscape review with Thad and his co-authors, who I should add include Dr. Timothy Quill, one thing we kept circling back to was voluntariness. You see this throughout the literature, throughout jurisdictions that have MAID, that regardless of what the law allowed, for example, advanced directives like they allow in the Netherlands, physicians themselves felt that there was something about a decision that would certainly end a person's life and reflect their desire to end their life now, that they needed for their own professional ethos to know that this reflected what the patient wanted now. And so this is something I realize I'm in a law school today surrounded by JDs, and I am not a lawyer, but I don't think this can be solved through legislation, through simply saying, well, it's allowed now, because as physicians and other practitioners will say, then you know what's going to happen. We're going to work around it. And if we feel that there's some concern about the capacity, we will not evaluate that person as eligible. So I think if there's any movement in a jurisdiction toward an idea of allowing MAID via advanced directives, there had better be a great deal of conversation with the practitioners you expect to be involved in this, or you're putting them in a terrible bind.
Can I follow up? There's, Susan, that's all right. There's just one question right on point. It's the other most upvoted question, and you've just touched on it, Dr. Berlinger, and maybe you could start the response. The question is there work being done to advocate for the MAID option for those with progressive dementia, such as Alzheimer's disease? And Professor Pope, it came up, I think, in your talk as well, that there's this criteria for capacity to make a decision. And yet the ironic challenge of a progressive dementia is that one may decide when they initially get the diagnosis, or as it's partially along, they would like this to happen, but it's not terminal in the sense that they may live with this for many years. And by the time they get to the point where their old self, what they might say, my true self, wanted to make this decision, they no longer have the capacity. And it almost seems that current laws wouldn't adapt for that. And yet what you've just described, Professor Berlinger, is that the need to make sure that that decision is made, with the right input, with clinicians involved. So can you all give us an update on what's happening in that space, and how do we navigate such a complex intersection of wanting to respect individual autonomy, but prevent abuse and potential misuse?
I'll just mention that back in March, the first debut of this report was at the International Conference on End-of-Life Law Policy Practice. Thad knows exactly what the full acronym is because he was the co-chair this year. And there was a tremendous presentation from every jurisdiction in the world that has some form of MAID policy. And I remember the presenters who were from Australia saying, dementia is a wicked problem when it comes to this, meaning not that it's an evil problem, but it doesn't fit neatly into these categories. So again, while one can talk about the laws, we are not sure what we think about these issues. Even the concept of saying then self and now self, some people say that that's not really helpful because it's the same body and it's the same family and it's the same money. But it is very challenging, and research with people who are facing an early dementia diagnosis, whether they're in a memory care clinic or another context, shows that this is on people's minds. They may assume that they are eligible for it. So it's not going to go away. And the more and more research on predictive biomarkers, or the idea of preclinical diagnoses and maybe starting medication early, may create more interest in this. So one of the things that's really crucial to do is to look at data that reflects the perspectives of people in this situation.
Thank you. Dr. Pope, did you want to jump in on this also?
Yeah, I mean, so let me just say, let's say you're an American and you were just, diagnosed with dementia, right? And it's progressed, and now you're worried about it. You don't want it to get to the late stages, the advanced stages. What are your options in terms of hastening your death? Well, in terms of MAID, you're right. You're completely locked out in the U.S. because so long as you still have decision-making capacity, you're not yet terminally ill, and by the time you're terminally ill, you're not going to have decision-making capacity. So you can't satisfy both at the same time. You can go to Switzerland, right? Americans do go to Switzerland to get MAID there because they can't get it here, and they don't have a terminal illness 6-month prognosis requirement. That's one option. What else? Well, there are advanced directives. So the problem, one problem with dementia is that even in Switzerland, you still have to have capacity, right? But that means the person may have to hasten their death earlier than they want, right? What they're worried about is what's happening 2 years from now. Right now, their life is fine, but if they have to act with capacity, they're forced to act earlier and end what they consider to be valuable, worthwhile life. So yes, the way around that is with an advanced directive. So Quebec has advanced directives. The Netherlands has advanced directives. Spain has advanced directives for MAID, right? We don't have that in the United States, but what we do have, and I think this is worth mentioning because Dr. Bollinger brought this up, is a massive, massive interest and spreading of advanced directives for VSED, right? Which are primarily for people with dementia. So you would say, when I get to this late stage of dementia, stage 6, stage 7 of Alzheimer's, and I'm dependent upon caregivers to spoon feed me or hand feed me, don't do it. I'm going to need it, but don't do it. And you will dehydrate and you will die in 10 to 14 days. So you have Dartmouth, you have a lot of organizations disseminating specialized VSED advanced directives. So I think until we in the United States do what Spain and the Netherlands and Quebec do, which is allow advanced directives for MAID, our sort of intermediate option is advanced directives for VSED.
Dr. Gann, did you want to comment too?
Sure, I would like to actually. And I think that it is definitely a wicked problem because there are a number of challenges with this. And I would say the two fundamental issues that are unresolved. It's not to say whether there should or shouldn't be advanced directives, but I think people need to consider this in policy, is that once you give consent to do something and then lose capacity, how do you withdraw consent? That is an unresolved wicked problem with dementia. What if you change your mind and you no longer have capacity? And I'll speak to that in one moment. And I think one of the other challenges is that the reality, we all know this, that we actually adjust and cope with things when they happen. And we know this from the mental health literature as well, that people will say, I would not want to live if this happened. Then something happens, they have a catastrophic accident, and they have a period of time where they need to adjust. In fact, they may feel suicidal for 6 months or a year. Some resolve more quickly, but many people cope. Not everyone does, and they actually regain a will to live. So this is an unresolved issue because some people project ahead that in this circumstance, that's what I would want. And then when they get there, they may not be suffering the same way, even if from the outside, we see the change in that person. The Quebec issue, it does pose some challenges in Canada because the national law does not have advanced directives. And Quebec has said that they will go ahead and have it. And, not to be fear mongering, I don't mean it that way, but just to point out some of these complexities. For any of the audience who are not aware of what's called the Netherlands coffee case, have a look and see what happened in that. But in a nutshell, it involved a person who had an advance directive. Once I get to this stage of dementia, I will want assisted dying. And what happened was when they got to that stage, or they were deemed to be at the stage that they would have wanted it and they'd lost capacity, they were alternately saying, I want it and I don't. They ended up actually having medication to end their life administered in their coffee without them knowing it. That didn't work. They became agitated, and they were actually then held down by family members and staff and provided an injection. And that was actually found to meet the standard of care. That case went through a legal challenge, and they found it met the standard of care. So again, these are things we have to think about. How do we revoke consent or change our minds when we have no capacity left?
I'd like to combine a few of the questions that we see here. Here we are in Minnesota, across the border from Canada, very close. And so this question of what should Minnesota and what should other jurisdictions in the US learn from Canada? And not just Canada. You mentioned the Netherlands, Dr. Gann, just now, the Netherlands, Belgium, Switzerland, you mentioned, Dr. Pope. What should we learn? Dr. Pope, you just talked about expansion, and in your talk you did. How far do we want to see that expansion? You know, one of the most common concerns over decades expressed about legalizing what we now call MAID is the slippery slope idea. So what do we learn from Canada and also jurisdictions that preceded Canada, like the Netherlands, where the practices are not limited to adults, where our colleague, Dr. Scott Kim at NIH, published a very interesting analysis of psychiatric euthanasia in the Netherlands. So, I mean, we've separated by this narrow border. What should we learn from Canada? And across the ocean, what should we learn from Europe as some of this expansion begins? And I'd like to throw in one other piece of the puzzle and maybe begin with you, Dr. Pope, because you talked about expansion. We have one question that a lot of people are interested in. You mentioned the statistic that as of now, so far, about 95% of patients who have used MAID in the United States and have been documented to use MAID in the reported statistics, there are also questions about how good are those statistics, are white. Why is that? So let me start with that collection of questions with Dr. Pope and then Dr. Gann and then Dr. Berlinger.
I'll just start with the last point you made. That needs to be studied. The question of the race. It's unclear how much is due to the fact that they're unable to access MAID. Maybe they want MAID but are unable to access it, or how much of it is that they just aren't interested and they don't even want it. Right? I think it was surprising to everybody when the California statistics started to come out, because Oregon and Washington and the early states are primarily white. And so the fact that most people getting MAID were white didn't surprise anybody when we're talking about Oregon. But California is minority white, right? So the fact that it's so high white percentage in California, where you have gigantic Hispanic population, that I think surprised people. But what I think we don't know, and I don't think the statisticians have dug into this carefully enough, is how much is that they don't want it and how much is it they can't get it. I believe it's probably both, because we have a lot of other data that Hispanics and African Americans don't use hospice as much. They don't complete advance directives at nearly the same rate as whites. And so MAID is not special, right? A lot of other end of life options also correlate in the same way that MAID correlates to race. On the first question about what can we learn from Canada, I mean, a lot, really, because they're doing so much and they're doing it so quickly. And I think that's good for the United States, right? Because in a sense, you have somebody else test things out. And I think we're producing a great amount of data. I think the number one thing I think that we can learn from Canada
and this is related to the race question, which is that the demand for MAID is probably way higher than the current supply, right? Dr. Gann described rates of 6% in Quebec and BC. In the US, we're talking 0.5% at best of all deaths are from MAID, right? So it's a more than 10-fold difference between MAID usage in the US and MAID usage in Canada. And again, we don't know how much of it is due to the fact that people, is access problems versus demand problems. But I do think that one thing we can learn is, I think US demand for MAID is way higher than the supply is. There's a lot of other stuff to learn because they're doing so many things. But I think that's good. And I think I'll just end on this. This morning or today, right? The UK Parliament is debating this. I think it's great that other countries, and you go back to Dr. Wolf, you talked about Justice O'Connor's use of the phrase laboratory of the states back in the 1997 Supreme Court case. We don't have just laboratories of the states. We have laboratories of the world, right? Ireland is, every legislature and parliament carefully examines this, right? And so we have a lot of careful examination and analysis of how MAID is working around the world. And I think that really can benefit evidence-based public policy in the United States.
So Dr. Gann, what should we learn from what's going on in Canada? And how does Canadian MAID look different? In the US, it does not include physician, or it's not supposed to include physician lethal injection and direct administration. So give us a deeper sense of what MAID looks like in Canada and what you think American jurisdictions like Minnesota should be learning.
So I would not want to presume to say what another jurisdiction should learn, but I would say what I think they should observe and then decide how you want to proceed. Because in terms of the first point you raised, it is very different here. And it is not only called MAID, it's still called medical assistance in dying. As I said, I think we actually coined the term. And in terms of that not referring to euthanasia in Canada, that's simply not true. Of those over 13,000 MAID deaths that I mentioned from 2022, so from 2022, of those 13,000, they reported that less than seven, not 7%, less than 7 were self-administered. All the others were lethal injection by the medical provider. And as we sort of touched on before, and it relates a little bit to this issue of commission and omission, but when we do things for others, when we facilitate things, it does make it easier. It's very different when it's a white lab coat providing you an injection versus you having a pill you take yourself. So one of the things is that the way we provide MAID does make a difference. The other thing I would suggest is this, that again, remembering that people seek death for different reasons, and people in different groups seek death for different things and different suffering. And to expand the idea far beyond simply this is about somebody's choice or somebody's autonomous choice, because I think most people wouldn't feel comfortable with thinking that the autonomous choice to escape poverty is society providing death, for example, or the autonomous choice to avoid suffering from an illness that you couldn't get treatment for would be kind of state-provided suicide. And we have had amongst our most prominent MAID assessors and providers here, some of whom have provided multiple hundreds of MAID deaths on their own, say that if somebody was on a wait list for care that could help long enough, they would consider that person eligible. And in terms of the statistics, you mentioned the slippery slope. In my opinion, Canada never had a slippery slope. I actually believe we've gone off a cliff. And I say this as someone who's not a conscientious objector. There is a huge difference between seeking death for kind of when you're very close to death versus for other times in your life. And I believe that the evidence suggests that's what contributes to the predominantly white people getting MAID in those jurisdictions, because those are all jurisdictions where somebody gets MAID for foreseeable death or a terminal condition. When you expand it, you see a different population getting it. And we already are seeing that in Canada. where as we've expanded it, we're starting to see some gender gaps appear. I mentioned the 2-to-1 gender gap of women to men getting psychiatric euthanasia in the Netherlands and in Europe. Part of the concern about that, by the way, is that actually parallels the 2-to-1 gender gap of women to men who attempt suicide when mentally ill, and most of them do not die by suicide, and most of them do not try a second time. They actually regain the will to live. And so the concern obviously there is, are we converting a suicidality that resolves to a 100% lethality by MAID? And in Canada, in some of the areas of more nebulous conditions, so you separate out cancers, but you look at, we have a large group of 15% of our deaths, the fastest growing one, is described as other. It includes things like chronic pain, frailty, etc., and also comorbid conditions. We are seeing a gender gap emerge in those, with more women than men getting MAID. And so I think my final piece would be to realize it is not the same thing for everyone, and to be honest about understanding what it's being provided for.
Very interesting. So Dr. Berlinger, I want to turn to you, and I want to also call attention in the QA to very interesting comments by our colleague, Dr. Joanne Lin, who points out that within a decade, we'll have millions of elders who can't afford housing, food, and medical care. You think broadly about the landscape of dying in America. So thinking about all of that, what do you think we should be learning from the Canadian experience?
Well, one thing is, just going back to the previous question, another reason about thinking about why is MAID so white is also because one thing we've been studying for the past a few years very intensely is who trusts healthcare, and how do healthcare organizations and healthcare practitioners behave in trustworthy ways. So MAID requires a very high degree of trust and participation with healthcare systems. The evaluation process, the request, you have to start somewhere with the doctor. So if you are not inclined in any way to trust that you are going to be well done by through a healthcare system, you might just stay clear of that. I do think that one thing we learn across the borders, and that I mentioned Professor Lewis at University of Minnesota Duluth Medical School, is it's really important when you're thinking about aging, end of life, what people view as a burden, what people view as a benefit, is to learn from researchers who are deeply embedded in these communities, rather than any form of generalizing about what white or non-white population want. I mean, Professor Lewis's research at both Minnesota with the 11 tribes in your state, and also in Alaska, where he's an Alaskan Native, is really very striking in terms of the approach that he takes. And I don't know that he's ever looked at MAID specifically, but you wind up with very different cultural constructs of dementia, for example, depending on what community you're in. So certainly not one size fits all. I do think with respect to Canada, it's very important in the United States that we don't say, well, it's going on in Canada, therefore that's where we're going. That's a problem with a slippery slope, that we're not, the United States is much more restrictive. We're more like Australia than we are like Canada. Canada's more like the Netherlands. But I think conferences like ISIL that Thaddeus co-chaired are really important as opportunities for gathering information and understanding each other's data. We have to commit to learning what's really going on in different jurisdictions. And Thad will know the name of this, there's also now a professional community of practitioners in MAID jurisdictions in the United States. I don't know that everyone is a prescriber, but the idea of airing the issues that are coming up in practice is very often very important. Dr. Gant has raised those as well, saying when I'm in my particular province, my particular area of practice, here's what arises for me as a doctor. Here's what I don't object to. Here's the problem I see, because we need that practitioner eye perspective. And so because as I mentioned, just legislating is not going to solve the moral intuition problems, the what keeps me up at night problems of the practitioners at the sharp end.
Dr. Pope, did you want to squeeze in one more comment?
Just a quick, both Dr. Gand and Dr. Bollinger both used the term slippery slope. And I think it's worth reminding people that the reason Canada has the legislation it has is because Parliament really had a gun to its head. They had to pass C-14 because of the Carter case. They had to pass C-7 because of the Truchon case. And I think that's important to remember. They were pushed because they can't legislate the right narrower than what the Supreme Court already said was constitutionally protected. U.S. legislatures like Minnesota can do whatever they want. There's no compulsion or coercion or constraints on how they legislate.
Professor Wolf, could I just say 10 seconds that we won't be able to get to it today, but the next time, the follow-up program, we have to talk about insurance. There's a wonderful question about, does insurance cover MAID, and can life insurance deny you for using MAID similar to suicide exclusions? Minnesota is also home to some of the nation's largest healthcare insurance providers. Any discussion of healthcare in the United States comes back to insurance and money, and the questioner says maybe that's related to the inequity. So I know we're out of time, but teasing for the next great program. Thanks to all our panelists. Turn it over to Professor Wolf.
Well, we have a lot of great questions in the QA. I wish we had another 3 hours that we could easily keep going with this. You know, when I teach in this area, I always say to my students, if there is a lack of disagreement in the room, I'm doing something wrong as a teacher. This is one of the most difficult issues that combines law, clinical care, ethics, economics. It's a very tough and fascinating set of issues. We are indebted to our 3 panelists. What wonderful presentations and great engagement with our audience and each other. I'd also like to encourage the audience to take advantage of the resources that we've posted on the website. Some of it is work done by our 3 panelists. What we've posted is, of course, the tip of the iceberg, because there's such an enormous literature and important literature on this. I want to thank our audience for this is a spectacular set of questions that really helped us open up the conversation. And of course, a huge thank you to our expert panelists. Remember that we're going to be sending all audience members who are registered an evaluation form. We'd love to hear back from you. And that unedited video of today's event is going to be posted right away on our website for you to share, view again, use in teaching or conversation, with a slightly edited version posted within a week. So with that, I want to again thank our tremendous team. Nothing happens without that team and our speakers, and ask you to stay tuned, because we are going to be offering more webinars on this core issue of when law, ethics, and medicine collide. Thank you all for being here today. Goodbye.